afternoon, everybody. I'm Agar Sharma. I'm a fourth-year medical student from the National University of Singapore with a special interest in orthopedics. I'll be presenting a paper today on how we live in a brand new world in which we must question how important is the role of mentors in teaching surgical techniques for intramedullary nailing of intertrochanteric factors with the advent of virtual reality as an immersive learning tool. This was RCT. So let's start with some background. So acquiring hands-on surgical skills has always been a continual challenge for both trainees as well as residents in orthopedics. Current training methods each have their own limitations, and virtual reality technology in the past few years has gained much traction as a surgical education tool. Now we must question, is the traditional master-apprentice relationship still relevant in today's world of surgery? The aim of our study was to compare the procedural competency of medical students inserting a short femoral intramedullary nail, in an intact proximal femur sawbones model. So our methodology was that we had 30 participants, and we split them into a mentor-led group, a VR-led group, and a combined group in which they received both mentor and combined feedback, mentor and VR feedback. The inclusion criteria was they had to be a preclinical medical student with no prior exposure to short synthesis TFNA insertion, orthopedic instrumentation, and VR-based gaming systems. The exclusion criteria was VR-induced nausea and significant medical conditions. These are some pictures of the participants undergoing the study, mainly the VR group, and the photos shown show the VR prompts which the participants actually saw during the course of the study. So this is the participants actually undergoing the study, in which you can see them moving around to actually interact with the interface. We then scored the participants on two different scoring mechanisms. The first was a global assessment 5-point rating scale, which scored them on the basis of time and motion, instrument handling, knowledge of instruments, flow of operation and forward planning, as well as knowledge of specific procedures. Then we had a procedure-specific checklist for each of the different procedures they were doing. We started with the guide wire setup, and we ended with the distal locking screw insertion. So these are our results. So first, let's start with the global assessment 5-point rating scale. So our results for all of the different components were actually significant, and across the board, the group which scored the best was the mentor and VR combined group. This was followed by the mentor group, and the poorest performance was by the VR group. So the aggregate score was significantly higher in the combined group, with it being 13.2. The mentor-only group was 9.7, and the VR-only group was 5.4. The p-value was 0.0014. Participants in the mentor-only group also received significantly high ratings across all categories, and the across-category p-value was 0.016. This is significant. Then let's move on to the percentage pass procedure. So the procedure-specific checklist assessment demonstrated that participants in the combined group completed 17.5% more steps correctly than the mentor-only group and 40% more than the VR-only group. Both were statistically significant, and participants in the mentor-only group completed 22.5% more steps compared to the VR-only group. This was also statistically significant. Students in the combined group compared to the mentor-only and VR-only group significantly performed better for 4 out of 8 steps. This is significant, and these 4 steps included the more complicated steps, including guide wire setup, nail assembly, nail insertion, and the helical blade insertion. So let's discuss, what do these results truly mean? So the global assessment scale shows that actually the combined group performed significantly better overall in terms of technical proficiency across all the different domains. This is likely due to the benefit of task repetition using both the mentor and then using VR. The mentor-only group also performed significantly better than the VR-only group. This is probably because of the age-old philosophy of the see one, do one, which has been used in surgical practice for many, many years now. And there's the benefit of live demonstration, whereby the participants can mimic exactly what the mentor is doing, as compared to figure it out using VR. The VR simulation program does not have any demonstration of the procedure, and the participants must actually figure this out prior to performing it themselves. Moving on to the procedure-specific checklist, a combined group completed a significantly higher percentage of steps correctly compared to the other groups, again, primarily due to the advantage of task repetition. The combined group also performed significantly better than the mentor-only and VR-only groups for the steps I stated before, and this is likely because there were less than 3 steps required to complete each procedural step, leading to an easier efficiency in actually completing these steps. However, there are always limitations to every study, and the limitation with our study is that the use of preclinical medical students does not reflect a real-world scenario. In a real-world scenario, this would be used more for orthopedic surgery residents or trainees. Also, the global assessment scale is a subjective assessment tool, and it's not an objective one. Lastly, participants in the mentor-only and VR-only groups were only exposed once to each procedure, so some could argue that the combined group had double the exposure and therefore performed better. This was primarily due to resource and time constraints, and in the future we could consider another study in which we would allow equal time to all 3 groups. In conclusion, a combination of mentor teaching with VR simulation led to the best performance for global assessment and for procedural tasks. Further studies are required to determine if task repetition using VR alone can be successful in teaching orthopedic surgical techniques. This would really determine the future direction of residency training in orthopedics, which could even change the number of trainees we accept and also change the ways training is actually conducted. Thank you very much for your attention.